Just my great pleasure to talk about some of the highlights from the year 2022 in diffuse large B-cell lymphoma and Hodgkin lymphoma. And really over the last year, there have been a number of interesting insights, particularly in the realm of diffuse large B-cell lymphoma that I'll highlight. The first is a randomized controlled trial in frontline diffuse large B-cell lymphoma, the POLARIX trial. So this was a trial that randomized patients to 6 cycles of a polatuzumab R-CHP with a vincristine placebo versus R-CHOP, the standard of care therapy, with a polatuzumab placebo. And then following those 6 cycles of therapy on both arms, patients had 2 additional doses of rituximab for cycles in 7 and 8. It enrolled patients with an IPI score of 2 through 5 and stratified patients by IPI score. And you can see the other enrollment characteristics. This was published in the New England Journal of Medicine in the tail end of 2021, and really is the first randomized controlled trial in the front line for diffuse large B-cell lymphoma to meet its primary endpoint as being a positive trial. What you see here in terms of the safety and adverse events of the trial is that the Pola R-CHP arm shown to the left looks very similar to R-CHOP in terms of the major adverse events. When you look at peripheral neuropathy, those were quite similar, and there was actually a specific presentation on that at the ASCO meeting that showed in more detail that there was really no major differences in safety with neuropathy, with those resolving after completion of therapy for the vast majority of patients. The one place where there were differences differences in the rates of neutropenia and febrile neutropenia that were higher in the Pola R-CHP arm compared to R-CHOP. There really were no major differences with the exception of neutropenia and febrile neutropenia, with those being higher in the Pola R-CHP arm. But importantly, those did not translate into differences in infection rates between the two arms. When you look at this slide, this shows the updated efficacy results from what was presented this year at the ASH annual meeting. Shown to the left are the primary analysis that was presented in the New England Journal of Medicine with a median follow-up of 28 months. And to the right, you can see the analysis at 39 months. And you can see that the primary endpoint of progression-free survival still showed a separation between the Pola R-CHP arm shown in the orange and the R-CHOP arm shown in the blue. Where at 2 years, there was a difference in progression-free survival of 6.5%, so being 76% in the group that received Pola R-CHP. And that was maintained with much farther follow-up. So that works out to being a hazard ratio of 0.73 at 2 years for progression-free survival and 0.76 at 3 years of follow-up. The other important analysis that came out of this year's ASH meeting was this analysis that was also presented looking at circulating tumor DNA in the POLARIX trial. Now here, what are shown are both arms of the trial combined, looking at progression-free survival and looking at overall survival shown to the right. But what you can see is that those patients who had clearing of their circulating tumor DNA by cycle 2, day 1, shown in the blue curve, versus those patients who did not clear circulating tumor DNA, shown in the red curve, show marked distinctions in terms of the progression-free survival and in terms of overall survival, with a progression-free survival hazard ratio of 2.4 and a overall survival hazard ratio of 2.78, where neither one of those hazard ratios cross 1. This suggests that we can now tell with a great degree of certainty that those patients who have clearing of their circulating tumor DNA are likely to be patients that are longer-term survivors, both in terms of PFS and OS. What we really want to see in future clinical trials are ways to be able to translate these into therapeutic modalities that use circulating tumor DNA with early response assessment at cycle 2, day 1, as ways to be able to stratify patients and then to provide different therapies for those patients. What also will come out of this trial in a subsequent analysis is now looking at end of treatment circulating tumor DNA, and that may provide other insights for the ways that ctDNA can be used in the frontline therapy for diffuse large B-cell lymphoma.
Have you actually been using polatuzumab? Have you been able to access it? Have you tried to access it?
Yeah, so I was involved both in the polatuzumab clinical trials in the relapsed and refractory setting, and was on the U.S. steering committee for the frontline Polarix trial. So I've used it in both of those settings. You may be aware that the NCCN just recently added data from the Polarix trial to their guidelines. And so now we're really waiting to see what the impact that will have. Polatuzumab is now approved in over 50 countries, and we're waiting to see from other results kind of what impact it will have in the United States.
Have you attempted to access it in the upfront setting? And if you were to access it, or even if it got approved, would you generally use it in most patients, or would you maybe subset it out?
Yeah, when you look at the patients where it is relevant, essentially across the patients who are eligible for the trial, it looks to be active in those subsets. I think we need to be a little bit cautious about doing unplanned subset analyses of different subsets within the context of the trial, and there have been forest plots that have looked at that. I think that those are generally less valuable, except in areas where the subsets have been planned as parts of the analysis. But in general, for patient populations that would have been eligible for the trial, and those include the broader IPI population of 2 through 5, those are patients that I think this would be a valuable regimen to use.
All right, please continue.
Next, I'm going to turn to data from the REMIND study. So this is REMIND 2. So this is an observational matched cohort study looking at tafasitamab and lenalidomide versus systemic therapies. And as you recall, tafasitamab lenalidomide is a therapy that is approved as a combination for patients who are not transplant eligible and have had 2 or more lines of therapy. And what they did was they took several thousand patients that were pooled who had either received bendamustine rituximab or gemcitabine oxaliplatin with rituximab, and pooled as systemic therapies, and then performed a matched analysis to the tafasitamab lenalidomide trial of 81 patients. What you can see through the matching process, those more than 3,000 patients ultimately whittled down to about 75 patients who were matched to the group that received tafalen in the pooled analysis, and also in the BR and RGEMOX groups. The curves to the right show a comparison of those patients, where you can see that the tafalen group in the light green had improvement in progression-free survival compared to that matched cohort. And this was published by Greg Nowakowski in 2022. The other components of this are the L-MIND subgroup of patients who were treated for more than 2 years. And you can see that those patients who had either 1 line of prior therapy or more than 2 lines of prior therapy, shown in the light yellow curve, both had favorable progression-free survival if they were treated for more than 2 years on tafalen. But I will point your attention to the bottom left of the curves to see the numbers of patients who started off. So 16 in the prior lines of therapy, and 11 who had 2 or more prior lines of therapy, suggesting these are very small subgroups that we're following here. But this was presented at ASH in 2022 to show the durability of response for those patients who received L-MIND. This just shows a subgroup analysis of patients treated for greater than 2 years in terms of the safety, with the major toxicities being seen, being those that occurred in cytopenias with neutropenia, thrombocytopenia, leukopenia, and anemia. And that shows the all-grade frequency in those patients who had greater than grade 3 in person years, with neutropenia being the most common event that occurred in more than grade 3 toxicity. It also shows in year 2 and year 3 the toxicity that occurred when patients went on to tafasitamab alone. The next study that I'll turn to is the LOTUS-2 trial. So this is a single-arm, open-label phase 2 study of patients with diffuse large B-cell lymphoma in the relapse and refractory setting, where patients receive the antibody-drug conjugate lacastatuximab tesirine, a CD19-directed antibody-drug conjugate. And you can see there the ways that the drug was dosed, both in terms of the first 2 cycles and then after 2 cycles. And then patients, after completion of 1 year of therapy were followed up every 12 weeks for up to 3 years. And this just shows the response rates for that study with 25%, nearly 25% of patients achieving a complete response with a median progression-free survival of 5 months for patients in the LOTUS-2 trial. And this was published at the tail end of 2021 by Paolo Caimi and colleagues. This shares a follow-up publication from Dr. Alaruccio in Blood Advances in 2022, where he looked at the high-grade B-cell lymphoma subgroup of the loncastuximab tesirine trial. And you can see that the response rates in this setting also were quite high for this poor risk population, where you can see a response rate of 33% in that group, and the timing that it took to CR shown at the top half of the curve. Again, those light blue curves for individual patients in the swimmer's plot show relatively few patients, but you can see for those patients who were responders on therapy that those responses could be quite durable, even the high-grade B-cell population. This just shows the changes in overall health from a follow-up publication that came in 2022 in Clinical Lymphoma, Myeloma, and Leukemia, looking at the loncastuximab tesirine trial. Again, looking at the responders in the light blue dotted line versus non-responders, you can see that the overall health state for patients tended to improve with subsequent trial cycles of therapy for those responders who were able to remain on therapy. Next, I'll turn to another important randomized controlled trial that was presented in ASH of 2021 as one of the plenary abstracts, and then published in late 2021, and another publication that I'll turn to next that was published in early 2022. This first trial is the ZUMA-7 trial, so a randomized controlled trial of axi-cell CAR T-cell therapy versus the approach of giving sequential chemotherapy with platinum-based immunotherapy, and for those patients who are responders going on to autologous stem cell transplantation. And this just shows in this large randomized controlled trial of relapse refractory large B-cell lymphoma with 359 patients, the key eligibility criteria shown to the left, with 180 patients randomized to the axi-cell arm and 179 to the standard of care arm. And these important data really showed a benefit in standard of care CAR T-cell therapy for patients who were early relapsers of large B-cell lymphoma. So these were patients who were primary refractory to their first-line therapy or who had relapsed within 12 months. And you can see here that axi-cell had improvements over the standard of care arm of giving salvage therapy and going on to auto transplant for responders, meeting the primary endpoint of event-free survival, where the median event-free survival was 8.3 months in the axi-cell arm versus 2 months in the group that received standard of care, with a stratified hazard ratio of 0.4. This approach really stands to reason, given that we've identified in those patients who relapse early within 12 months, or those patients who are primary refractory, patients who are non-responders to traditional chemoimmunotherapy. So it stands to reason that an approach of giving more intensive chemoimmunotherapy of another type and going on to autologous transplant may not be as good as an approach like CAR T-cell therapy that is using a different modality of cellular therapy to address the refractory disease. There was a second trial that also addressed this Transform trial that confirmed this strategy. And this trial also took patients who were relapsed or refractory within 12 months after first-line therapy and randomized them to lisocabtagene silolucel as the CAR T-cell therapy versus standard of care with the addition of chemoimmunotherapy followed by autologous stem cell transplant. This trial did allow crossover, whereas the prior trial, ZUMA-7 that I showed you, did not allow crossover in that trial. And these are the primary results for the Transform trial that was published at the beginning of 2022 in Lancet by Manali Kamdar and colleagues. And what you can see here, again, was a benefit for the approach of using CAR T cell therapy here with Lysocell, with a median event-free survival of 10 months in that arm versus 2.3 months in the standard of care group. Again, with a hazard ratio looks quite similar to what I just showed you of 0.35 in this particular trial, again showing the benefit of CAR T cell for these early relapsed and refractory patients with diffuse large B-cell lymphoma. There was additional follow-up that was presented last year in 2022 in ASH by Jeremy Abramson that showed that benefit continued with additional follow-up with a stratified hazard ratio of 0.35 that was almost identical to what I just showed you from the publication. Again, with Lysocell having a marked benefit compared to what formerly was the standard of care for patients with early relapse. And here with an 18-month event-free survival rate of 52.6% for lisocabtagene siloluso versus 20% for that group that received salvage chemoimmunotherapy, followed by the approach of autologous stem cell transplant for those patients who are responders. So this really has supplanted that traditional approach for patients as we care for patients in 2023 and beyond. What I'll turn to next is another approach for patients with relapse disease, and that is the role of selinexor. This was a large study that had 267 patients who were ultimately eligible for enrollment of the trial, and you can see the 34 patients who ultimately were analyzed for the primary endpoint. A follow-up publication came from Dr. Schuster in Clinical Lymphoma, Myeloma, and Leukemia in 2022, looking at subsets of those patients who received selinexor in terms of the response rates according to their prior treatment and their refractory status. And what you can see here, when you look at the overall response rate for selinexor across different populations, those patients who had 2 lines of therapy previous to receiving selinexor had an overall response rate of 27.8%. But you can also see those who had 3 or more lines of therapy had response rates that were quite similar of 30.9%. Likewise, responses occurred in patients who had prior transplant, but were lower in those patients who had no prior autologous stem cell transplant, probably owing to the fact that these were patients that were not eligible for auto transplant for some other reason. And you can see that the response to the last line of therapy really was a determining factor in terms of the response to selinexor, where those patients who had had a PR or CR to their prior line of therapy had an overall response rate of nearly 36% versus 16% to those patients who were not responders.
So, of course, we've been talking about selinexor for a while in our myeloma programs, and the issue of tolerability has been coming up, particularly in the community-based oncologists, the investigators. Joe McHale's a good example. They use it a lot. They feel like if they're very aggressive with supportive care, the patients do well. Have you actually used it yourself? And just kind of curious what you've seen or what you've heard about tolerance.
Yeah, I have used it and was part of the selinexor trials when I was at Emory. I think, one of the challenges with this agent is the way that patients feel when they're receiving it, with the kind of the asthenia and malaise that patients experience that really makes it difficult to tolerate the drug, particularly at the higher doses. You'll see from the slide that I showed you previously that really these results are being described for those patients who receive selinexor at the 60 milligram dose. The group that got allocated to the 100 milligram dose really has not been as well evaluated, in part because that dose was not as tolerable. In the myeloma group, they really have found ways to be able to adjust the dosing of selinexor, spread it out over time, and see ways to make it more tolerable to patients. That has been much less well explored in the realm of diffuse large B-cell lymphoma, in part because we don't really know whether the efficacy that we see in the settings where we're giving the doses that I just described really would hold with lower doses and with spreading doses out. And the efficacy that we see is quite modest compared to some of the other options that I've already described and some that I would. And so I think, in instances when you're using selinexor, you really want those patients to be responders and to have the benefits of the efficacy. So it has been a little bit more of a challenge here to balance the effectiveness of the drug versus the tolerability.
Yeah, I mean the preliminary data doesn't look as exciting as some of the other things you talked about, but I like the mechanism of action. I just like the idea that it's sort of different.
Yeah, it is nice to have a number of options for patients with relapsed diffuse large B-cell lymphoma. That's really changed dramatically in the last 5 years as compared to when we had we had autologous transplant, and after autologous transplant, we had allo transplant or various forms of chemotherapy that we might alternate. Now we have a whole host of options for the patients in that setting. So moving on to some agents that are still in development in diffuse large B-cell lymphoma, I'll talk next about the bispecific antibodies. So this is a series of different agents that include both a component of the agent that is CD20 directed, so a CD20 directed antibody, as well as a CD3 directed antibody that brings T cells in close proximity to the CD20 positive diffuse large B-cell or also follicular lymphoma or other CD20 positive malignancies. So the first of these trials that I'll talk about was published by Dr. Dickinson in the New England Journal of Medicine in 2022, looking at glofitamab. These are the pivotal results from the phase 2 trial in relapsed and refractory diffuse large B-cell lymphoma. I think some of the things that we've learned about the bispecific antibodies is that we can potentially mitigate some of the early cycle toxicities that we see in cycle 1 with cytokine release syndrome or CRS by giving pretreatment with obinutuzumab in this case, and also using step-up dosing. And so you can see here in cycle 1, there was administration of obinutuzumab followed by step-up dosing of the glofitamab until a full dose of 30 milligrams of glofitamab was given on day 1 of cycle number 2. And the primary endpoint for this study was the best response rate or CR rate by independent review. And so these show the results in relapsed and refractory diffuse large B-cell lymphoma for glofitamab. Shown on the curve to the left are the percentage of patients, starting with those patients who were in complete response, so at 100%. So you can see 61 patients in all who were in CR, and then following them over time. And so the median duration of complete response at the time of publication was not reached. When you look at the progression-free survival for all patients, that median progression-free survival was 4.9 months, with 37% of the population being progression-free and alive at 12 months within this study. When you look at the safety profile of glofitamab, what you can see here, and is quite similar for the other bispecific antibodies, is that that major adverse event was cytokine release syndrome being the most common, with that being predominantly grade 1 in severity for most patients, although there was some grade 2 and grade 3 CRS, and that predominantly occurred with cycle 1 of therapy. The other major toxicities tended to be cytopenias with neutropenia, anemia, and thrombocytopenia. Next, I'll turn to the epcoritamab trial. So this is another CD20, CD3 bispecific antibody that is administered subcutaneously. These show the results of the EPCOR phase 2 trial that included patients with large B-cell lymphoma as well as patients with follicular lymphoma grade 3B. And this had a cohort of 157 patients. Again, step-up dosing was used, and you can see the ways that epcoritamab was administered subcutaneously at a dose of 48 milligrams given weekly for the first 3 weeks, and then every 2 weeks for cycles 4 through 9, and then once monthly for cycle 10 and beyond. And these show the results again for those patients who were responders with a CR rate in this trial of 38.9%, an overall response rate of 63%, and with a median follow-up of 10 months, that duration of response at a median was 12 months. The progression-free survival curves shown here show a median progression-free survival of 4.4 months in the curve to the right. And this was published by Catherine Tiblemont in the JCO in 2022. Looking at the safety of the epcoritamab trial, this looks relatively similar to what I just described for you for the other bispecific antibody, glofitamab, where you can see the most common toxicity was CRS, again occurring most commonly in the early cycles of therapy, with 32% of those being grade 1 toxicity in the CRS. And the other common toxicities were fever, neutropenia, anemia, and fatigue. Next, moving on to odronextamab in relapsed and refractory diffuse large B-cell lymphoma. In that patient population, this was looked at where the primary response rate, the primary endpoint for the trial was overall response rate by independent review, and was presented at ASH at the end of 2022. So in terms of the odronextamab trial, the overall response rate was 49% with a complete response rate of 30.8%. The step-up regimen was used in these cases as well. And you can see that the overall response rate across two different approaches to the step-up regimen was really quite similar in terms of the overall response and complete response rates observed. And this shows the duration of response curves and the duration of complete response curves for this trial. You can see here, starting with 64 patients who were responders, median duration of response of 10.2 months, and then looking at the complete response duration with 40 patients who were complete responders, a median duration of complete response of nearly 18 months in this trial. Again, these responses and durability of response look quite similar across the CD20, CD3 bispecific antibodies. And finally, I'm going to close out with some data from the Hodgkin lymphoma studies. This first study is looking at the Echelon-1 data. As you recall, that was a pivotal trial in the front line for Hodgkin lymphoma, looking at the combination of AVD with brentuximab for patients with advanced stage Hodgkin lymphoma in comparison to the former standard of care ABVD in the frontline setting. And you can see that patients had an end of treatment PET and then follow up every 3 months for the first 36 months, and then every 6 months until the study closure. And what's new for 2022 in the publication of these results by Steve Ansel in the New England Journal of Medicine is both the data on progression-free survival showing the benefit of AAVD versus ABVD with a 32% risk reduction. If you recall, the very first publication of these results described a modified progression-free survival that is more commonly considered something like event-free survival. Here are shown the former progression-free survival data for this curve with a median follow-up of 73 months, meeting a hazard ratio of 0.68. I think what's more compelling are these data, the overall survival results from this study, where you can see that the overall survival favors the use of brentuximab AVD versus ABVD with a 41% risk reduction and a hazard ratio of 0.59, really for the first time showing an improvement in overall survival in a tolerable regimen in the frontline setting for patients with Hodgkin lymphoma. And this has really moved into the standard of care for patients who are eligible for this regimen with long follow-up in this study. The other thing is that this regimen is now moving into other settings, now looking at the first-line treatment of early-stage unfavorable Hodgkin lymphoma. And this is a trial from the ERTC and the LYSA group looking at the criterion for enrollment there. And you can see that this involved a 2-to-1 randomization to 4 cycles of brentuximab AVD versus ABVD followed by radiation, with the primary endpoint being PET response after 2 cycles of therapy. And this showed a difference in the PET negativity rate for the group that received BV-AVD of 82% versus 75% in the group that received ABVD. And you can see the progression-free survival curves shown to the right, again favoring the group that received BV-AVD and published in the JCO at the tail end of last year. And finally, I'll close out with a novel antibody drug conjugate that is used in the relapse setting for follicular lymphoma in trials in data that were presented by Alex Herrera at the SOHO meeting in 2022. This is candidamalumab tesirine, so an anti-CD25 directed monoclonal antibody conjugated to the same antibody drug conjugate tesirine that I described earlier in the presentation in diffuse large B-cell lymphoma. So this is an ongoing phase 2 clinical trial, and you can see the ways that dosing was given here, with the primary endpoint being overall response rate. And in looking at the response rates that were observed in this trial, you can see that a total overall response rate of 70% for patients enrolled in the relapse setting for Hodgkin lymphoma here, with a CR rate of 33% for those patients, and a progression-free survival curve shown to the right, with a median of 9 months, with about 10 months of follow-up. I think it's important to note that there are adverse events that are unique to this agent, changes in hepatobiliary function tests, in skin and nail reaction, as well as autoimmune related abnormalities that we see with PD-1 inhibitors, and Guillain-Barré syndrome that's been seen in selected patients. And so it's important as this moves forward to really understand the specific toxicities that we see with this agent. And there was an additional exploratory analysis that was also presented by Alex Herrera at the ASH meeting in December, looking at different subgroups of patients and looking at the response rates, both in terms of overall responses and complete responses to that. In particular, I'll point your attention to those patients who had prior stem cell transplant or not, where you can see that the response rates and complete response rates were slightly higher in the group that had received prior stem cell transplant. And then looking at the bottom in terms of patients who had had a response to their PD-1 inhibitor in the past, and both patients who were refractory or relapsed after a PD-1 inhibitor had high response rates and high CR rates, suggesting that this is an agent that holds some promise across various subgroups in relapsed Hodgkin lymphoma. And we'll wait to see where this pans out in the future for the role of this agent in relapsed patients. Thank you all for your attention. Really an exciting year in 2022 for both Hodgkin lymphoma and diffuse large B-cell lymphoma. And we look to see how each of these trials and some of the new trials progress in the year ahead in 2023.